Thank you, Muge, for that very kind introduction. It's a pleasure to actually be part of the tutorial series. Whenever I go to the tutorials website, I find this sort of succinct sort of summary of what tutorials are meant to be. And I liked it, so I just put it up there. This is not Informs doing it, it's me sort of putting up that. And I hope I can aspire to sort of at least meet partially some of the things stated in that quote. So I'm the presenting author of this tutorial. The title is Interventions for Patients with Complex Medical and Social Needs. This research was funded by the National Science Foundation, a couple of grants, a grant prior to this, as well as a more recent grant that ends in 2025. And so this is research that I've been working on for almost like, I would say it's a distillation of work from my lab for the last 6 to 10 years. So hopefully you find it interesting. I want to make sure I acknowledge all the co-authors in this tutorial. We have Sindhura Prakash, who is here, a PhD student in industrial engineering at the University of Massachusetts Amherst. This is a UMass team, by the way, so it's a full UMass team. Ali Jafari, also a PhD student in industrial engineering at the University of Massachusetts Amherst. Informs did the scheduling wrong, and his talk is actually right at this time at a different room, so hopefully he'll make it after the talk. Arjun Mohan, a former master's student who also worked on this, who did his thesis on this topic, and some of his results are in here. And Dr. Chaitra Gopalappa, who's my colleague. She's an associate professor in mechanical and industrial engineering, again, UMass Amherst. I also want to mention that Dr. Gopalappa is leading a broader effort in this field, and therefore I think her input was very important. So she's leading something called a multi-sector modeling consortium, which brings together health, social determinants, and interventions together. And she's bringing in people from nursing at UMass, public health at UMass, but also it's an initiative that goes beyond just UMass. She's also connecting with researchers at other universities. So yeah, at UMass we have a nice group that is sort of working on these problems. I also want to acknowledge my collaborators at the Camden Coalition. I realize it's been 10 years now since I first met Erin. I've met Dawn since, and been in touch with her since 2016, 2017, but recently she's become a collaborator with us. And I think this organization is really one of the sort of, one of my favorite collaborations. I've worked with many large organizations like Mayo Clinic, Massachusetts General Hospital, Veterans Affairs, but a small organization like this, which does very rigorous research, it's been very fruitful collaboration with them. So every time you look, so I'm going to explain the context for the study first. So every time you look at any data set, whether it is a particular city, a particular region, state, or country, you see a very specific pattern. And that is that you have a small number of people who have a lot of chronic conditions. So this is a report from the RAND Corporation for the United States. You see that 40% of the US population has no chronic conditions. 18% has one chronic condition, and so on. 13% has two, and so on. So when you get to individuals who have 5 or more chronic conditions, you see that's only 12% of the population. 12% is still millions of people. It's not a small number. If you include 4 or more, if you include 4 plus, so basically that's 19% of the American population has 4 or more chronic conditions, and that's about 60 million Americans. This is an astonishingly large number, even though the percentages are small compared to those who are apparently healthy. We also see that essentially people with 5+ chronic conditions have a very big share of the total expenditures. So you see that they account for 41% of total expenditures. And if you include 3, 4, and 5, then basically that's 67% of total expenditures are accounted by this group of people, of patients. Yes? Yes, it includes everyone. Yeah, so it comes from a data set called the Medical Expenditure Panel Survey. So they survey households all around the country. And I think they also have data for children, infants. Yeah. The other fact is multiple chronic conditions can happen independently. They don't have to be linked with social factors, but often they also are linked with social and behavioral factors, such as somebody who's homeless or has housing instability, somebody who has substance use disorders, poverty, other socioeconomic reasons. So that's one of the sort of themes of this. So you have medical complexity, and that goes hand in hand sometimes with social complexity. And that's the whole idea of patients with complex medical and social needs. However, multiple chronic conditions is an independent problem on its own, as we'll find out later on. So there are many organizations that are trying to help these individuals in various ways. This is probably, you could say, these are organizations that are trying to help the most vulnerable groups in any city, region, or health system, for example. And usually they use multidisciplinary teams to assist such patients. They could involve physicians, they could involve some combination of physicians, nurses, community health workers, and social workers. So there are actually dozens and dozens of such groups. In fact, if you go to any place, you'll always find a group that's doing something along the lines of helping people with either medical needs or social needs. I've just given some examples here. So Kaiser Permanente is a provider in California. They have complex care programs. The Veterans Affairs, VA, has an impact program that basically also helps patients who have high costs and high medical complexity. A community health worker program at University of Pennsylvania. And these last three that I listed here are organizations that I've had like site visits to. There was a conference organized by the Camden Coalition last year, and we've had a site visit with the Boston Healthcare for the Homeless. Obviously, as the name suggests, it is about helping people who are homeless in the greater Boston area. Last week, this year's conference last week was in Pittsburgh, and I went to a site visit to a group that's called the Neighborhood Resilience Project, and their emphasis has been to reduce trauma that's caused because of violence in that community. So it's not, so each organization, the size varies. They can be federally qualified health centers, they can be Veterans Affairs, it can be large or small. So there are actually many groups around this country that have this focus. And finally, the Camden Coalition, whom I acknowledged earlier, they are a case study for this tutorial. And I'll sort of show an example of what they do, and hopefully that'll set the tone for what we mean by the term complex care interventions. So here's an example. This is from almost 10 years ago, but it still is very relevant. So you have here a timeline for an individual who's 52 years old, has 3 diagnoses: hepatitis, congestive heart failure, and diabetes. Those are 3 chronic conditions. They're quite difficult to manage. In addition, so this is the medical complexity. You have the social complexity, where the individual is homeless, is unemployed, uninsured, has substance abuse, and mental health issues. So it's clearly, there's a lot of complexity in this particular patient. So what you see here is a 9-month timeline before the care team at the Camden Coalition started working with this individual to help him, and then a post-enrollment timeline. So 9 months after the intervention started and 9 months before the intervention started. And what you see, the blue lines are emergency department visits and stays at an inpatient hospital. The blue ones are stays at inpatient hospital, and the red marks are emergency department visits. The care team tried to engage with this patient early on, but that didn't work. So you had this sort of phase of high number of hospitalizations. I started working with this person in about July, and worked for 9 months later. And you can see that there's fewer hospitalizations and emergency department visits in this particular case. So the kinds of help that were provided by the Camden Coalition care teams included connecting this patient to a drug rehabilitation center, providing transitional housing, connecting this person with a cardiologist because there's a congestive heart failure problem, and essentially trying to get the Social Security income approved. The social worker worked with this patient to get Social Security income approved, as well as try to get insurance for this patient. So in the 9 months pre-enrollment, this person had 3 ED visits and spent 61 days in the hospital. This 9-month period, the total expenditures were $112,000. After the care team helped the patient in the 9 months after the total ED visits, there were no ED visits, there was only 1 inpatient stay, and costs came down pretty dramatically. It's very misleading to sort of present this one example. It doesn't quite work out this way for everybody. There's a lot of stochasticity in how things go from pre to post. And actually, one of the dangers of this is just doing a pre and post comparison, because that can often be faulty, as we'll see later on. But still, this was the ideal sort of case that the care teams wanted to see in hoping that the interventions would work. Now, it did require the enormous amount of effort for the care team to make this difference. So 139 hours of a social worker's time in this 9-month period were needed. And I'm not even putting those, if I put like every encounter that the patient had with this individual on this timeline, it would be so busy that it would be too cluttered, so it's not even included. So the good news is the Camden Coalition has been collecting this very detailed data on how the care teams interact with the patient, how much time is spent in each encounter, and they have a very good database that we ended up using. So this is kind of an example of a complex care intervention. The other point I want to make is when I saw this example back in 2014, when I did an open house at the Camden Coalition, they also had a picture of the person because that person had consented to release their information, and that person felt that this patient felt that he was helped a lot by the care team, and so he was okay with sharing this information. And at last week's conference, I saw somebody, and it was exactly that same photograph that I had seen 10 years ago. So at that conference, this person was there. He's now also running managing a food pantry in Camden, and is also trying to start a program for low-income housing for other individuals in Camden, having learned all this. So that's a kind of outcome that we don't quite see here. We only see sort of the hospital before and after, and of course there's good reductions. But this is the kind of long-term thing you want to see where individuals have become, their self-efficacy is much higher, and they're able to do a lot. So it was a very, very interesting conference visit last week. I think it was great to see. I've been presenting this for many years, and then to actually see the person and actually talk to that person was wonderful. So I have 2 parts to this tutorial, and in the first part, I'm going to sort of shift the tone a little bit. I'm going to focus much more on medical complexity, specifically on identifying sort of patterns in how chronic conditions co-occur. That's going to be the focus, and we're going to use unsupervised learning methods for this purpose. And I'm going to use the Medical Expenditure Panel Survey, one of the data sets that I mentioned earlier. That's going to be my sort of example to illustrate this co-occurrence patterns. And then in part 2, I'll return back to the Camden Coalition. Not only did they collect data on care team encounters with the patient, they are one of the few groups that has done a randomized control study. It's very logistically difficult to execute, very challenging, but they did it. It was a multi-year randomized control trial that they worked with MIT to do, and they published the results, and I'll come back to that later on. So going back to this idea of chronic condition co-occurrence, or the medical complexity part, what our goals here are, how can we identify commonly occurring conditions in patients. And we also want to see how these different conditions relate to each other. For example, there may be diseases that are metabolic diseases. Some diseases may be respiratory diseases. Other diseases may be musculoskeletal diseases. How do these different body systems, diseases that belong to different body systems, relate to each other? So this analysis it's important for complex care planning, but it's also useful from an epidemiological point of view. Maybe it might suggest things that people have not looked at carefully. This type of analysis may help in identifying unknown connections between diseases that have not yet been established. But it also lays the groundwork for knowing that if you have this combination of diseases, what types of medications, what types of lifestyle changes, what types of specialty care do you need for such patients? So to sort of test this idea out, I've been working with the Medical Expenditure Panel Survey. It's a data set that is released by the Agency of Healthcare Research and Quality. About 28,000 to 34,000 individuals are surveyed every year across the country. And this information is released to the public. It's de-identified, anonymized, and released to the public. So anybody can download this data set. And it's a very rich data set. Their final target is expenditures, as the name suggests. But to get to those expenditures, they have to get to the specific sequence, and they don't need the sequence actually, but they do tell you for every person. For example, this one here, this is an encounter sequence for one person, a 69-year-old female, who had all these different types of encounters, from hospital inpatient stays to office-based events to home health events. So you have this very detailed information that you can assemble from the Medical Expenditure Panel Survey. Not only do you have that, you also have each office-based visit is also further subdivided into whether it's a primary care visit or cardiology visit or a nephrology visit, and so on. So you also have the ICD-9 or ICD-10 diagnosis codes associated with each of these encounters. ICD refers to the International Classification of Diseases, and there are several versions of it. So there's a version 9 and version 10. So what we did is we took a patient's information from a year. We collected all their ICD-9 or ICD-10 codes related to their encounters. And then because the ICD-9 and 10 codes tend to be very granular. So for example, if you have diabetes, you might have a particular complication in diabetes, so it would list that in the ICD-9 or ICD-10 code. We wanted slightly more aggregate information. And so therefore, we use something called clinical classification software, which is also Agency of Healthcare Research and Quality's software. And we use these clinical classification software codes to find out what combination of chronic conditions did this person have in that year. Okay. So we do this for every individual. We identify all their encounters, the ICD-9, ICD-10 codes, and then find out what chronic condition combinations each individual has. So let's see how the example chronic condition combinations look in this case. So we have, for example, 3 patients here. These are the CCCS diagnosis codes that we are using. So the first patient here has these 1, 2, 3, 4 different chronic conditions. Lipid metabolism disorders is simply high cholesterol. Anxiety, depression, that's self-explanatory. Non-traumatic joint disorders, that's a musculoskeletal problem. And then you have this other sort of long category, which is also a musculoskeletal problem, spondylosis. So this is a person with 4 conditions. This is an individual with 5 conditions. Again, you can maybe see some overlaps here. So you can see that lipid metabolism disorders or high cholesterol does overlap with the previous patient. But patient B's combination is different from patient A's, right? Patient C's combination is also different from the other 2 patients. However, patient C has, I think, 4 diseases in common with maybe the first, I can't remember which, maybe B and C. Patients B and C have an overlapping set of diseases. So when we made this list for every individual, and we listed out their unique chronic condition combinations, we found in a 4-year period an astonishing 34,880 unique combinations. Right, so this is a very, very heterogeneous and very large number. And so essentially, the reason it's important is people have overlapping conditions, but they become more and more unique. Their combination almost becomes their signature, because every medication or every lifestyle change, you have to consider not just one condition, but sort of this constellation of conditions. So as I mentioned earlier, there are 60 million Americans with 4+ conditions, but they have a very high degree of heterogeneity because of this combinatorial mixing of diseases. This is a very unique and interesting property, what I call the combinatrix of disease combinations or something like that. So the question is, how do we make sense of this long list of chronic condition combinations? How do we infer patterns from it? And for example, what are the most common overlapping diseases in these combinations? And once we know that, then maybe that can be the basis of clinicians making decisions on medications, lifestyle, or planning for specialties, and so on. So let's move on to sort of one of the main parts of this first part, which is how do we mine these co-occurrence patterns? So we have this data set of N patients and P diseases. It's a binary data set. So we have each row is a patient, each column is a disease. And if a person has a disease, you have a 1. Otherwise, it's a 0. Right? And what we're interested in is what subsets, these are subsets are also called item sets. What subsets or item sets have relatively high support in this data set? So at the moment, we're not considering things like age and gender. So ideally, you want to segment the population first based on, let's say, 65 plus, 40 to 65. But for illustration purposes, we're not doing that. We're just saying it's, you have a set of patients, and then you have these diseases, and we want to find the subsets or item sets with the greatest support. So let's have a little bit of notation here. So you have item set is denoted by this kind of fancy K, math K. And so that's basically just a subset, some subset of the P diseases. And what we have here is basically telling us that, OK, well, what is the support of that subset? How many patients in that data set have that subset of diseases? So that is TK is the support. It is essentially a probability estimate of, based on that data set. So what we're interested in is we want all subsets such that the support value is higher than some predetermined threshold T that we consider to be high enough. So this is, again, because of that combinatorial structure, this is a somewhat computationally challenging problem. So how many subsets are there? Well, it's actually 2 to the power 189 if I have 189 diseases. Then you can't explore all possible subsets. You need an algorithm to list out and create these subsets for you in a systematic way. And that algorithm is called the a priori algorithm. And by the way, this whole procedure is called frequent item set analysis. It's also called market basket analysis. Market basket analysis, because of its, it used to be used in the grocery store or retail setting. So if you're buying bread, you're also buying cheese, you're also buying peanut butter. So that would be a trio of things you would purchase together. So you have millions of retail transactions to which these kinds of this a priori algorithm, frequent item sets algorithm would be applied. In our case, of course, we're interested in not purchasing items. We're saying which diseases subsets co-occur together. I think the best name for this is probably association rule mining, and maybe it's not as commonly known, but it's actually, as you'll see, it's a much better term because it actually establishes associations between diseases and these item sets. So the a priori algorithm, how does it work? It first looks at all individual diseases, and it considers only individual diseases that have a prevalence higher than this pre-specified threshold. Those diseases that have prevalence less than T or support less than T, it eliminates. Then it looks at, now, so you have a surviving set of diseases that have support greater than T. You then look at all possible pairs of those diseases, and then include only those pairs that have support higher than T. If a pair has support less than T, you discard it. And then with the trios, you once again do all possible combinations of pairs and singletons to get the trios. And again, if the support is greater than T, then you include it, otherwise you don't. So you keep doing this until you reach a point where you can't actually, there's no subset left which has a support higher than that pre-specified threshold. So we want this threshold, if we keep this threshold too large, then we won't actually see those chronic condition combinations. So we want to keep that threshold somewhat small in this particular setting. So that's why I call it relatively high support. So let's look at what data we use for this. So we used the 2019 Medical Expenditure Panel Survey. Our binary data set was 28,104 patients, and we had 189 diseases. The support threshold was 0.0003, and that equates to if a subset or item set has 10 people, 10 patients who have that subset or item set, you get included. Otherwise, you don't. So that's still, the 10 is still, I mean, if you see a combination that has 10 people have that combination, that's still rare enough and interesting enough. That's why we include it. So here's a sampling of item sets. Again, these are disease subsets. Previously, I showed you combinations, which is the whole thing. These are subsets or item sets. So once again, cholesterol and essential hypertension is basically high blood pressure. So these are the two most common pair. In fact, the support is 0.098. That suggests that about 10% of the population has this pair. You have something over here, a combination of size 4, and the support there is 0.002. But that's still higher than the 10 that we need. So actually, these are not, this is just a sampling of the subsets. If you look at the full list of subsets, you'll get hundreds of them. So essentially, the a priori algorithm creates a database of all these item sets that can then be used by clinicians, because if they're searching for a certain item set, then they can look into it. A more structured way of showing this is this visualization, and I know that the resolution is not perfect. I think what we could do is we could actually move to the PDF here. That's why I had the, yeah. I don't know if this is easier. So this may be a little easier to see. So essentially, I've listed subsets of size, subsets or item sets of size 4 and 5, and the number of patients who have that subset. So these are disease codes. So this is a subset of size 4. And what I'm trying to show here is that this subset has this code 204, which actually is a musculoskeletal condition. This is 49, 53, 98. This is actually diabetes, high cholesterol, high blood pressure. So these are all coming from the metabolic diseases, the metabolic disease group. So actually, each disease group is given a different shape. So you have circles, you have squares, you have half circles, you have triangles, and then you have diamonds. And so we found that all of these subsets of 4 or 5, notice that their support is higher than the minimum of 10. We said that 10 was sort of our minimum cutoff. Is higher than that minimum of 10. What is interesting is that these five larger sort of groupings of conditions are often mixing together in these chronic condition combinations. And so somebody might have, for example, this is a heart disease, this is a cardiac problem, this is a musculoskeletal problem, this is a metabolic problem. So you have an intersection of different types of diseases merging together. And I think that's why I thought visualization was a little more useful than just simply listing names of diseases. Okay, going back to my slides. So what you could do is, it's not, so the association rule mining frequent item sets is not just about identifying the item sets. It can also allow you to show the relationships between different item sets that don't share a disease together. So you define something called an antecedent and a consequent. And in this case, the antecedent is metabolic diseases, this trio here. And you define a consequent, which is basically this pair of respiratory diseases, asthma and chronic obstructive pulmonary disease, also known as COPD. So what you can show here is you can use measures which are called confidence and lift, but a simpler way of looking at it is confidence is nothing but the probability of the consequent given the antecedent. So it's just a conditional probability or the risk of developing the consequent given that you have an antecedent. Lift is simply telling you it's a ratio of the joint probability of the antecedent and consequent divided by the probabilities, the individual probabilities of the antecedent and consequent. So if A and B1 were independent of each other, then probability of A intersection B1 would be equal to roughly probability of A times probability of B1. And this ratio would be close to 1. So if you get ratios that are much higher than 1, then that is a suggestion possibly that these disease groups that belong to different body systems might be linked. It's not a conclusive proof. It's not a causal thing. It's just giving you an indication. Right? So in this case, for example, the lift between this trio of metabolic diseases and this consequent of two respiratory diseases, we said that 1 is relative independence. We're getting 4.23 in this particular case. So maybe there's a suggestion here that maybe these things are, this is what clinicians or epidemiologists could look at to further explore, are there any physiological mechanisms that connect these two body systems? And remember that maybe 50, 100 years ago, even the connection between diabetes and heart disease was not conclusively proven. It was only after the Framingham study that was done in the last century that this was decisively proved. But there's plenty of other things that we don't know yet that could potentially be explained, or at least be explored, by this type of analysis. Let's take a look at this antecedent and this consequent, the same antecedent, metabolic. The consequent here are two mental health conditions, anxiety and depression. Mood disorders is another word for depression. And the lift here is 1.8, still higher than 1, but not as high as the 4.23 that we're getting in the previous case. Right? So what the a priori, the association rule mining and a priori algorithm does is it creates a database of item sets. Then it connects and looks at all item set pairs that have strong relationships. And you can specify, give me all item sets that have support higher than this and lift higher than this. And I can explore that set. So the answer is not a single solution. It's a database that you can use. So that's what the use of a priori and association rule mining is in this particular case. So as I was doing this, I thought, OK, so maybe it's an idea occurred to me. So there's this large language model that has been put out by Mayo Clinic. It's called Open Evidence. It's also featured by the New England Journal of Medicine. And so I decided to ask, I didn't know. So I noticed the lift was very high between metabolic and respiratory diseases. So I decided to ask it, are metabolic diseases linked to respiratory diseases? And in fact, the answer, usually for open evidence, the answers also give you references on which their conclusions are based. So in this case, the metabolic diseases do seem to have very specific links that have been established in the literature. What I thought is that in addition to this, which is summarizing the content of papers, we could also have visualizations of these types of, maybe much better than how this is put up, visualizations that could also assist clinicians. So you could integrate this into tools like this. That's just a thought. I talked to a physician. He told me he uses this, and he usually looks for diagnosis codes and stuff, and he asks and queries this for that purpose. So we're getting close to the conclusion of part 1. There's actually another big part to this. It's called latent class analysis. But if I go over it, it's probably going to take me another 10, 15 minutes to explain the theory behind it. The tutorial does have an explanation of latent class analysis. What I'm going to do now is overview other unsupervised learning methods that, that we are looking into, of which latent class analysis, which Sindhura is working on as part of her dissertation, has been summarized in the tutorial. So let's look at very quickly. What the problem with a priori, it just gives these massive databases of different combinations. It doesn't give you clean-cut answers. You have to look and explore these databases. If instead we took a clustering approach, and all of these are clustering algorithms, even latent class analysis, it sounds different, but it actually is clustering. Graph partitioning is also can be linked to clustering. So Arjun Mohan, the master's thesis student, used a hierarchical agglomerative clustering where the disease codes, depending on how similar or dissimilar they are, in this case, he's using a dissimilarity index. So the lower the dissimilarity index, the more similarity a pair of diseases has. So this is a tree diagram. It's often called a dendrogram. And you can create this type of visualization, and you can see that diseases start to merge together. And these colored clusters were defined by Arjun, and he was the one who sort of made these decisions. But this is one sort of way, and it's a well-known algorithm in the unsupervised learning literature. My student Ali Jafari, who, as I said, he's presenting this very thing in a different session, as informs had an error in their scheduling. But what we could do is we could represent diseases in an undirected graph. So each node is a disease, and the weight on each edge would be some measure of correlation. For example, lift, or it could just be correlation. And what you want to do is now you have this massive graph, and you specify that you want to have k cuts of this graph, which means you want to partition the nodes into k disjoint subsets so that the total sum of that correlation value is maximized within each partition. And so in this way, you can formulate this problem as a mixed integer program. And so this is our sort of most homegrown algorithm in which we can define our objective functions, and we've been exploring this kind of k-cut, as well as 2-cut. 2-cut only extracts one set of nodes from this whole set. K-cut is a little more general. So anyway, so this is another approach. The last approach, which I mentioned, is latent class analysis. It's too much to go into the theory of latent class analysis in this particular presentation, but I want to sort of highlight what it does. It also defines clusters. It calls them classes. In this case, for example, there are 7 different classes. This is a study that used data set from California, Kaiser Permanente, a set of patients who were very complex. It used data from that data set and then applied latent class analysis, and this is the output of latent class analysis. So it creates 7 different clusters or classes. It also tells you for each disease, these rows here are names of diseases. It tells you for each disease what is the prevalence of that disease in each class. So if you see a bar like that, that means that, well, stroke is very highly prevalent in class 2. You have dialysis status is very highly prevalent in class 1 compared to other classes. So you can look at this kind of prevalence of these binary sort of diseases and then start to name the classes. So because dialysis is very significant and dialysis happens with end-stage renal disease, the authors called this class end-stage renal disease. And because stroke is a kind of catastrophic thing and post-stroke paralysis is a catastrophic thing, they call this class neurologic and catastrophic. So the naming is an art that comes afterward once you run the latent class analysis. So it's not a perfect method. There's a lot of overlap. So you're not only interested in those bars that are high in relation to other classes. Some bars may be low, but still may be higher in relation to other classes. And that could be interesting, too. So one of our collaborators at the Camden Coalition with whom we're using latent class analysis said that it's as much an art as an exact science. So So we're trying this with, in our work with the Camden Coalition. Yeah, so I couldn't get into the details of this, but it's in the tutorial. Let me check how we're doing on time. So it's 1:27. So there's obviously this is just the tip of the iceberg. There's a lot that could be done with this research. I think it's open as to when you have quantitative continuous variables as well as binary and categorical variables, how do you do clustering? That's still something I haven't figured out fully. I mean, there are methods, but it's sort of what are the inner mechanics of that? Also progressions of diseases, including age, gender, lifestyle factors, it's a whole research area in itself. And then how do we move beyond just associations? Can we do something about causal learning? That would be another area of future research. So anyway, so this is the end of part 1, and as I said, it was focused largely on the complexity of medical conditions. We're going to start part 2 now, in which I go back to the case study, and we saw that example of the Camden Coalition intervention, and we're going to study that problem. And it's it's much more applied than this one. This one was also applied, but we had lots of algorithms going on. In this one, it's much more about Camden Coalition's story and how it's evolved over the years. So this is part 2. I'm just going to have a drink of water. It's very tightly. So this part looks at more the operational features of complex care interventions. So we just studied sort of the population segmentation side of things. But now we are here. How do complex care interventions actually work in practice? So what we did for this tutorial is we reviewed the literature of all organizations that have done complex care interventions and have tested them. And we tried to abstract the key elements of how these interventions work. So usually you have an eligible patient population. It could be like people who are homeless, for example, is an eligible patient population. It could be people who have high risk of stroke. It could be people who have 5 or more conditions. Those are different ways in which you can define an eligible population. It could be people who are facing post-traumatic stress disorder. It all depends on the organization and what they're trying to do. So once they've defined the eligible population, you enroll the patient, and then there is a series of interactions, which is basically a stochastic process, which unfolds in time. The stochastic process consists of like interactions, touch points between the patient and one or more members of the care team. It could also be, these touch points could be home visits, the care team visiting the patient's home, or making a phone call on behalf of that patient. So all of those options are possible. The patient need not be present. It can just be a social worker making a call to a housing agency, for example. And so you have an intervention. It usually has a fixed duration, maybe 3 months, maybe 1 month, maybe 6 months. It could be 2 years. Again, it depends on the organization. And then once it's done, you usually want to track outcomes during and after intervention. You might want to track mortality. You might want to track inpatient or hospital readmission rates to find out whether this interaction, the time spent by the care team in helping the patient, which I also call the dosage, in the same way that you have a dosage of medicine, here you have a dosage of time that is spent with the patient. Did that have an impact on all sorts of measures, including qualitative ones such as self-rating of mental health, physical health, satisfaction with the care provided, and so on. So this is the basic structure of most complex care interventions. And I'm going to describe to you sort of Camden's experience. So the history of the Camden Coalition, it began in 2002. It was founded by a family physician. His name is Jeffrey Brenner. And he was a primary care physician, and he wanted to help individuals living in Camden, New Jersey. And so he started what is called a citywide coalition. The name coalition comes from the fact that it's not just one practice. It involves social service agencies, churches, it involves community representatives. So all of them come together for breakfast meetings to discuss what can we do with what's going on in the city and individuals who need help. So this was going on, and they piloted their very first intervention in 2007. It was a very basic one. It wasn't very systematically planned, but they started with a nurse practitioner, social worker, and community health worker. So what happened, what shot Camden Coalition to fame was an article by the surgeon and writer Atul Gawande in 2011. It was called the Hotspotting in Healthcare, or Hotspotters, I think. And that really brought them recognition. There was also a nice 13-minute video on PBS Frontline, which describes this pretty well. And Atul Gawande is in that video as well. So they got national recognition, and they got funding from the Center for Medicare and Medicaid Innovation in 2012, and to pilot something larger. And so they partnered with MIT, Amy Finkelstein, a professor of economics, and they did a randomized controlled trial from 2014 to 2017. So I want those of you who work in healthcare, you know how difficult this is, right? So you have an operational intervention, something that's about staffing and giving time to patients. I've done many projects, and we don't know whether it has an impact or not, right? And so this is one of those, what attracted me was this is a group trying to rigorously test a staffing intervention in a randomized controlled trial, right? So that was really amazing. I was not involved in that, but I started my collaboration around the same time that the randomized controlled trial started. I visited their open house during my last sabbatical. It's a long time ago, 10 years ago. There's been another sabbatical in the intermediate period. And within 3 months, I had a data set that I could, they were that good and that open with their data. And that's not something I've seen with larger organizations. The results, so we also published the amount of care team time that was needed in 2019. The results of the randomized controlled trial with MIT were published in the New England Journal of Medicine in 2020. And then we received that data set as well, the randomized controlled trial data set as well, which Sindhura has been using over the last 2 years to do several analyses. So that grant started in June 2022. So if we look at this intervention, how it, some more details. So what happens is that the care team at the Camden Coalition gets real-time feeds from 3 of the area's hospitals. And these real-time feeds, let me just check that how I'm doing on time. I think I have 10 more minutes at least so that we can ask questions. So these real-time feeds from these hospitals comes to the care team. They triage to see if there are patients who would need assistance. So care team triages the patients who would benefit from the intervention. The triage criteria are these: 2 or more inpatient admissions in the last 6 months, and 2 or more of these characteristics. More chronic conditions, 5 or more medications, active substance use. So if any 2 of these are checked, and if the patient has had 2 or more inpatient admissions, that's the eligibility to be included. So the care team contacts and visits the patient while the patient is still in the hospital at the bedside. If the patient consents, the intervention begins. And that's day 0, essentially the start of the intervention. So I think I've probably mentioned what kind of help is provided. The help ranges very widely. It could be anything from providing housing. It could be connecting the patient with a primary care provider. It could be helping patients find healthy food options in grocery stores, managing and reconciling medications, because some of these patients have a lot of medications. So this is, I think, probably kind of implied. And so the intervention is highly tailored, highly customized to this patient's specific needs. So we had lots of questions here. How do patient interventions vary in terms of care team time, which is dosage? How do they vary in terms of the duration of the intervention, 3 months, 6 months, 10 days, and so on? And what is the impact on metrics such as inpatient hospitalizations? And that's where the evidence from the randomized controlled trial comes in. There's also impact on things like access to primary and specialty care, And then this part is about staffing a multidisciplinary care team. It's not something I will have time to cover. And I want to point out that Sindhura is presenting a talk on Wednesday morning, 8 a.m. I'm not sure if everyone will be there, but it's going to go into the depth about this sort of scheduling piece, which is in the tutorial summarized, but I'm not going to have the time to cover it. So I'm going to focus on these first two parts. And maybe that too relatively quickly, hopefully, so that I have maybe 8 minutes before I start questions. So this is the data set, and I think it has several features. You can see that maybe the median chronic conditions is about 5. This is the racial mix of the population. We also have very detailed history of patient encounters with each staff member to show you something more on that. So you have like examples of 3 patients who started their intervention on day 0. And the colors tell you what type of staff member worked with that patient on which day. The shapes tell you, like, was it a home visit? Was it an enrollment visit? Did the staff member accompany the patient to a primary care physician? So you have this kind of longitudinal progression of the intervention. And we have this for, I think now, maybe close to 800 to 1,000 patients. And so this is, I have mentioned this is an underlying stochastic process, and it's very difficult because you don't quite know what the time between events is going to be. You don't quite know what the duration of each encounter is going to be. And so it's a challenging scheduling problem. But this is the data set that we had and we used. We used this data set to create these kind of trajectories, which says a patient starting on day 0, this is day 0, as the days progress in the intervention, what is the cumulative care team hours, time spent by all members of the care team as the patient progresses in the intervention. And I've also listed some other key milestones, such as the first home visit, initial PCP visit, and so on. So you can take this and you can do this for every individual. And we did this for 531 individuals, which we published in 2019. So what you see here is essentially the same thing, days since the intervention began. And this here is the cumulative care team hours. What you have, each point is basically telling you when the patient finished the intervention. Where did they finish the intervention? This person finished the intervention, had about 170 hours, 170 days in the care coordination program, and needed about 140 hours of the care team's time. So one trajectory that we just shot can be seen here. We didn't want to do 531 trajectories. It would be too busy. So we have tremendous variation. So you have people who finish very early, and many of them are incomplete. They didn't quite finish the intervention. So if you look at this box, it basically says you have low hours, shorter duration. You have 90 patients in this box. Only 20%. Yeah, so 18 graduated. So 20% of the patients graduated in that. Graduated means they've met their goals. If you look at this box here, this is basically the same number of patients approximately. That's about 87 patients. 75 out of those 87 patients graduated with having completed their goals with the care team. So graduation is a qualitative decision that is decided between the care team and the patient. So this is a kind of ad hoc clustering where we divided it into this 2D points into 6 equal-sized kind of clusters and saw what the graduation rates were. So what you can see, the main conclusion here is there's this tremendous variation in the dosage. Some people need 20 hours, some people need 200 hours. Sorry, some people need 20 hours, some people need about 180 hours. So keep that in mind as we think about the randomized control trial. If you think of a randomized control trial for a drug, you usually have a certain dosage of the drug. You take that drug, or if it's a vaccine, you get that vaccine, and then that's randomized. And some people get placebo, some people get the vaccine or the drug, right? What we have here is something different. People are being randomized into those who get help from the care team. And then there's a control group that is not receiving any additional help. It's care as usual. But if you get help from the care team, your dosage is varying wildly, as this graph shows. You also have different levels of engagement going on. Some patients engage a lot, some patients don't engage as much. So not only is there great heterogeneity in the covariates, there's also great heterogeneity in the amount of time needed from the care team, in the amount of engagement. So anyway, so these about 400 patients were in the intervention group, 400 in the control group. It took three and a half years to finish this enrollment. That's kind of how costly it was to execute this trial. And it was published in the New England Journal of Medicine in 2020. It was a highly anticipated study. People really liked the Camden Coalition and what they were doing, and they wanted it to succeed. And so they worked with Amy Finkelstein of MIT, and they found the results came as a big disappointment because there was no difference in, let's say, readmission rates, number of readmissions, days in the hospital, any of these metrics between the control and intervention groups. So it takes some amount of courage to be able to publish something like this when you've staked your whole organization's claim on helping patients with these needs and still going through this trial and publishing it, right? So this is not uncommon. Many complex care interventions have mixed results. Some are successful, some are not. One of the things that is also there in the New England Journal of Medicine paper shows that this is the quarter or the 3-month period before the intervention began. This is the average number of admissions. So both groups are about like 0.1 before the intervention. Control and treatment are both about like around 1. And both come down in the quarter after intervention. So it's not that readmissions, the number of admissions didn't decrease. They decreased, but they decreased for both. And this phenomenon is called regression to the mean. When you're capturing people at a level of very, very high utilization, it is just naturally more likely that in the next time period, you're going to see a slight dip in utilization. So this phenomenon is well known, and that's why you need a control group. Because if you didn't have a control group, you would say that, yeah, this is the treatment group. It went down, and this is actually a significant change. So you would say that there was a big improvement. But the control group shows us that it's not really true. However, since that first study, there have been secondary analysis of the randomized control trial. And these are showing lots of positive benefits. For example, this study here in JAMA Network Open shows that patients who had high levels of engagement had statistically lower readmission rates than people who had low levels of engagement. And there was a very specific methodology that was used to kind of illustrate this. Intervention patients were also more likely to follow up with primary and specialty care than control patients. So these were, again, 2 successes. This is published in Health Affairs recently. And so these were now saying that, well, yes, there was no difference. But if you look at specific groups within intervention and control, and again, you have to be very careful because you don't want to fish for things that don't exist. But they are showing that actually there were some differences. And one of our studies, which we are working on right now, is can we find subgroups that are meaningful, clinically interpretable, where we see a difference in outcomes between intervention and control. And I think that's something we're working on. In the ORMS literature, Bertsimas et al. Published something called Identifying Exceptional Responders in Randomized Trials. It uses a mixed integer programming approach to search the covariate space for regions with enough patients in them in both intervention and control. So you have the whole covariate space. You're going to slice the covariate space into, let's say, boxes. And in that box, you have both control patients and intervention patients. And then you have the treatment effect. And if you can find regions in the covariate space using integer programming, then you can maybe say that, yes, in this region, we saw a difference. So that's something we're doing, but we're doing it using latent class analysis, the method I discussed earlier. So I think there's actually lots of things to ponder on here. I think I have two more slides. So one is about the closing thoughts, which basically I think is reiterating things that I've already said. I think it's more constructive to actually have questions rather than sort of me going over these things. We have 13 minutes or so. I think it's much better served by us, having a discussion. So I think I want to pause there and I think take questions.